Hello, my name is Carrie Allen, and I'm a consultant pharmacist and a certified geriatric specialist pharmacist. I'm here to talk to you today about psychoactive, also sometimes called psychotropic, medications in long-term care facilities. Psychotropic medications are basically any medication that's meant to affect your mind, your emotions, or your behaviors. So typically we think of anti-anxiety meds, antipsychotics, antidepressants, sometimes things called mood stabilizers, which are usually anticonvulsants. You might think of Depakote, those kind of medications. They're meant to stabilize the neurons so that people aren't acting aggressively, those kind of things. In some cases, we use hormones as psychotropic or psychoactive medications. For example, men taking Premarin, which is a conjugated estrogen hormone, for sexual aggression towards others. There's a lot of information out there about psychotropic medications, but one of the most important things to realize is that the federal government has an entire act devoted to this, the Omnibus Budget Reconciliation Act, originally from 1987, sometimes called OBRA 1987 or OBRA 87, that basically wants to limit the use of psychotropic medications in the elderly, which is a good thing. For example, residents of long-term care facilities, skilled nursing facilities, those kind of things. Because we want to focus on legitimate reasons for use, not medicating for staff convenience. We all know those pictures of people in the 60s and 70s and 50s just drugged out of their minds, leaning against a corner, drooling while the staff is playing cards or hanging out over on the side. That's not what we're looking for. We're not trying to over-drug people. It also focuses on periodic trials of medication dose reduction or withdrawal. So we want to make sure that we're using it for something specific and that we don't use it for too long, and we use it at the lowest possible effective dose. So psychoactive or psychotropic meds are basically chemical restraint. It's very similar to physically tying someone down, but you're doing it in a chemical way because you're holding back or altering the person's behavioral tendencies or urges. We really want to do this as little as possible because it's not always a good thing. And it can lead to lots of other complications, infections, wounds, those kind of things. In nursing homes, we need consents for psychoactive medications because they do act as chemical restraints and they do have significant side effects. Residents and families need to know what they're signing up for, so make sure these consent forms are accurate. So many times I see the listed side effects for a medication that don't go together, and yet there's a family member who's signed off on that. There's a lot of emotional angst associated with agreeing to have your family member basically chemically restrained, so you want to make sure that they know what they're signing for and that the risk-benefit is something that they're okay with. You want to rule out other causes of behaviors before you just start medicating people for no reason. So for example, a medical reason. Do they have a urinary tract infection and that is making them act unusually? We probably don't need to medicate them with Ativan for the rest of their life just because they got sick for over a week and acted a little oddly. Are there environmental causes, like loud roommates who disturb the sleep, or are they napping all day and therefore can't sleep at night? Or are they napping all day because their roommate's keeping them up all night? Those kind of things. Psychosocial causes, and this is individual. It's how people develop and behave and react in a social environment. Some people are just naturally loud and outgoing. Some are quiet. Some are more suspicious of others and reserved. Some are outgoing and very touchy-feely. So you don't want to set necessarily the touchy-feely person next to the suspicious and reserved person because they might not get along so well. If they're not getting along so well, do we need to medicate them both so they do get along? Probably not. We need to move them apart. So don't just jump to medications if at all possible. We need to individualize. Some people are less social, like I mentioned, so they might not want to participate in group activities. This may not mean they're depressed or withdrawing. It may mean that they're just less social. We need to individualize based on each person's natural tendencies. Some people don't speak English as a first language, and they might be uncomfortable if we're doing activities like Scrabble that are English-based, or vice versa. Maybe you've got someone who primarily speaks English or only speaks English, and we're playing, Spanish Scrabble, or Spanish bingo or something in the game room. Do they want to participate in that? Maybe, maybe not. Someone's roommate or family may have just died. Give people time to grieve and an outlet to talk if needed before we just start throwing medications at them. And for nurses out there, you might think, well, that's not really my responsibility. I just call the doctor. But you have to realize every time you call a doctor for something to do, They tend to want to prescribe medications, and it's based on what you're telling them. So nurses generate a lot of prescriptions maybe without knowing it. With the psychotropic medications, as I mentioned, we want to use the lowest possible effective dose. We want to decrease the side effects, so that generally means lower doses. We want to make sure the medication is still relevant. Sometimes when people age and they have dementia and it progresses, that delusion or agitation that required medication has now changed, or it's disappeared as that disease progressed, or maybe as they get used to their surroundings. Behavior monitoring. Nurses are definitely in charge of behavior monitoring. It falls mainly on the nurses and the facility, not the physician in skilled nursing facilities. So when I'm looking as a consultant pharmacist at the forms for the behavior and side effects, I get a lot of zeros. No behaviors, no side effects. No behaviors, no side effects. But then I look on the PRN MAR, and there's PRN meds used all the time for anxiety or acting out or agitation. And those two things then don't match up. Or we'll see a resident get a medication for a newly developed movement disorder or a tremor, but there was nothing on the side effect sheets. It could be related to a medication. So monitoring really needs to be more consistent and more meaningful and much better documented than it usually is. I see it done. I see people intervening and instead of giving a medication, redirecting a resident, but we don't often write it down. What we need to do is really document what we're doing. Hopefully with computers and things getting a little bit more automated as time goes by, it'll be a little easier, but until then we need to make sure that we're writing stuff down. Some medications have both psychotropic and physical effects. So for example, those anticonvulsant epilepsy meds that are used as mood stabilizers can affect how people think and their alertness, and that can increase fall risk. Some anti-anxiety meds can affect your short-term memory and also increase fall risk. Some meds used for tremor can lower your blood pressure and your heart rate, which will in turn increase the fall risk. And you can sense a theme there. There's a lot of stuff that's going to go on where it's affecting the mind and affecting the balance in the body. We all know how traumatic and catastrophically detrimental a fall can be to an elderly person, so we have to be super careful with these meds. Make sure that we're using them for specific targeted behaviors, not just general things like anxiety, agitation, psychosis. With anxiety, when? Why are they having anxiety? How does it manifest? Is it just before showers? Agitation, is it only when a certain person goes in their room? Is it only at certain times at night? Psychosis, what kind of psychosis? Are there delusions? What kind of delusions are they? Are they getting worse? Are they getting better? Wandering. Wandering is not an excellent reason to chemically restrain someone. Unless they're a danger to themselves or others, redirection is usually the best approach. Now with side effects of psychotropic drugs, and we've been going through this a lot and we'll keep going through it, one of the ones that are the most dangerous class-wise are antipsychotics, and they're so popular these days. You see them on TV, you've got the Abilify commercials, all those things where it's Abilify, it's an antipsychotic, but it's also helping with depression. Still, it's an antipsychotic. And studies show that there is an all-cause, so every cause, increased risk in mortality for elderly persons with dementia taking these meds. So basically, if you have dementia and you're elderly and we're prescribing you an antipsychotic, you are more likely to die than the person next to you who is not taking an antipsychotic. That's very serious. There's a black box warning on that from the FDA, and we really want to look at risk versus benefit for things like that. Is it worth the risk to give people these antipsychotics? We get so used to seeing it, but they're still very dangerous. And I'm seeing more and more side effects and more serious side effects as we use these medications more and more. Some medication name examples of antipsychotics, just so you can think about this in your head: Abilify, Risperdal, Seroquel, Haldol, Thorazine. I didn't used to see a lot of Thorazine, and I'm seeing a lot more of it come back. People taking antipsychotic drugs are at risk of developing certain side effects known as extrapyramidal symptoms. These are the movement-related extrapyramidal symptoms, or extrapyramidal symptoms are movement-related. So it's repetitive, involuntary muscle movements. You might start in the face, like lip smacking or blinking or grimacing, and it might be an undeniable urge to be moving constantly back and forth, akathisias. They can be Parkinson's-like. So it might be even smaller. It might be tremor. It might be rigidity. It might be slow moving or shuffling gait. It might be pill rolling or air guitar with the hands, chewing or rabbit nose movements, throat clearing or grunting. It might be restlessness, people moving back and forth or pacing or tapping, shifting body weight leg to leg. Now we might also look at that as an anxiety-like symptom. And we might look at that again as Parkinson's-like. So what will happen is you'll get people on antipsychotics, and then they get these side effects. We start prescribing Parkinson's meds. We start prescribing anxiety meds, all to fix what these antipsychotics originally started, and that's called a prescribing cascade. More side effects of psychotropic drugs. One is called tardive dyskinesia, and it is a version of extrapyramidal symptoms, those movement disorders. But at this point, when it goes to tardive dyskinesia, it's permanent, even after the medication is stopped. That's why it's just so important that we monitor, and we monitor well, and we catch things early. Nurses are so good at assessments, and they need to use that skill to make sure that we're not going to harm someone by using these medications. And it's on an ongoing basis. I hear a lot of, oh, well, they've been on that since I've been here. Well, that doesn't matter. It can develop at any time. You need to look at these people with fresh eyes every time you assess. Further on, so you've got your extrapyramidal symptoms, and then maybe you've got some EPS. A similar related issue is called neuroleptic malignant syndrome, and it's related mostly with antipsychotics, but can occur with some other drugs. It's usually high fever, muscle rigidity, altered mental status, fast heart rate, changes in blood pressure, sweating, sometimes fixed eye movements where the eyes are rolled up and you're staring straight up and you can't move them. It's a painful condition. I've asked people who've survived this condition, and it can cause death. You want to be on the lookout for this. Didn't used to see it. With the increase of antipsychotics, I am seeing more and more of it being suspected by physicians when they're sending residents out to the hospital for incidents that nurses are calling them about. With antipsychotics, you've got to start low dose, slowly increase, try not to increase too much, and get them over with. Get them done as soon as possible. Don't keep people on antipsychotics forever, if at all possible. With these side effects, you can see why the low doses are important, why we only want to use them for specific reasons, and we want to use them for short periods of time. Now, being mindful of the fact that there is such a thing known as Parkinson's disease that does occur in elderly people and some younger people, such as Michael J. Fox, there are also side effects, just like the antipsychotics I mentioned. So tremor or trembling, hands, arms, leg, jaw, could be Parkinson's disease, could be a side effect from an antipsychotic. Rigidity or stiffness of the limbs and trunk, possibly in the face, the slow movements, the problems with balance and coordination. Is it Parkinson's disease? Is it a side effect from an antipsychotic? Parkinson's disease has its own set of meds that we treat it with. Mirapex is one, Requip, Cinnamate, amantadine, sometimes in combination. These meds, because they work on dopamine, can actually have a detrimental effect such as hallucinations or delusions or paranoia, reckless behaviors such as gambling or odd sexual behaviors, poor impulse control, and just flat-out psychosis. So when you have someone who has these kind of side effects and they're on Parkinson's meds, is it because of the Parkinson's meds, or are they having delusions and they really need an antipsychotic? A lot of the time, it's the Parkinson's meds. And so what we need to do is decrease the Parkinson med dose or change to a different med instead of just throwing on an antipsychotic. Serotonin, we hear a lot about that probably in the last 15 to 20 years especially. Serotonin is a hormone. It's a neurotransmitter found in the brain. It's also in your digestive tract and in your platelets found in your blood. It works in transmitting nerve impulses, regulating your mood, relieving depression and anxiety, regulating aggression, your appetite, metabolism, nausea pathways, your sleep cycle, your body temperature regulation, and your sexuality. It affects a lot. When these pathways go awry, we tend to prescribe drugs. And we've heard a lot about serotonin reuptake inhibitors and other meds that might increase serotonin, such as Celexa, Lexapro, Zoloft, Prozac, Effexor, which actually affects norepinephrine and serotonin, St. John's wort, which is an herb, some migraine medications. Serotonin is great. Increasing it can be helpful to people, but you can get too much, which leads to serotonin syndrome, which is manifested by severe rigidity, changes in mental status, fever, sweating, gastrointestinal disturbances, large involuntary movements, tremor, restlessness. And when these things occur, it can be serious and life-threatening. We usually tend to send people out. However, there's a camp of people who believe that serotonin syndrome is the very severe fatal occurrence at the end of the spectrum, and lower levels of the syndrome exist in day-to-day life where people are actually having side effects, where they're having small amounts of rigidity, small changes in mental status, small gastrointestinal disturbances, some tremor, some restlessness attributed to these meds that increase serotonin. So it's something to look for and monitor as people are on them. Typically, you see it when people are in serotonergic drug or drug combinations or high doses, but it can occur in anybody. Be aware that we prescribe lots of meds that affect the serotonin pathways in the elderly. Nausea, vomiting meds, a lot of them affect serotonin. Your antipsychotics can affect dopamine and serotonin. Some sleep medications and some antidepressants, of course. Let's make sure that we're trying to keep people off of 2 or more antidepressants at a time. A lot of the times we look at that and we say, okay, there's 2 different mechanisms of action, but we don't always know exactly what these meds are doing. So we have to be careful. Multiple meds usually leads to multiple problems. Less meds is usually better. Antidepressants combined with migraine medications or herbals or those anti-nausea medications, like I mentioned, can cause serotonin syndrome. Perhaps at the extreme end, where they need to be hospitalized, perhaps just with smaller side effects. I'm going to lump anxiety and insomnia together. Anxiety is part of life and aging. And there's some harsh realities for these people that are in our nursing homes. And if you talk to the people, you'll know what I mean. They have a lot going on. It seems like, oh, maybe they're sitting there and they're in their jammies and it should be calm, but it's not. They have friends and families just like we do. They have things going on in their lives. They may have roommates dying. They may be dealing with end-of-life issues. So anxiety is definitely part of their life, and we should take that seriously. Anxiety can lead to insomnia, or perhaps if you just have insomnia and you haven't been sleeping well, you can have feelings of anxiety. Typically, we treat this with medications such as Ativan or Xanax. These are benzodiazepines, and they work to sort of help shut down or relax certain parts of the brain. Buspar, which is an antidepressant. Restoril, another benzodiazepine. That's more for sleep, but it also can affect anxiety, decreasing it. Ambien, it's not a benzodiazepine. It works mainly on sleep, not anxiety, but again, with that cycle with sleep and anxiety, it can be used. Valium and Klonopin, both benzodiazepines, and these last 2, that Valium and the Klonopin, are so long-acting, especially in the elderly. The elderly have trouble getting rid of medications as it stands. When you use really long-acting medications, such as Valium or Klonopin, it can be very detrimental. They have a lot of sedation, short-term memory loss, confusion in general with benzodiazepines. When you use the long-acting ones, you get a lot more side effects, and you get a lot more of the hangover effect and effects on balance and gait. There's something called disinhibition that can happen with benzodiazepines, like your Ativan, your Xanax, your Valium, your Klonopin, whereby someone might be anxious. You'll give them the benzodiazepine, and they may start ripping off their clothes. They may start crying or getting very upset, and it's having not the effect that we want it to have. That actually is a semi-common effect of benzodiazepines on certain people. And in that case, it might not be a very good class of medications for that person. We need to move on to something else. And that's something you're going to want to record on your behavior monitoring. For anxiety, low-dose medications for short-term management is important, especially for anxiety coupled with insomnia. It's not a good thing to long-term medicate someone for anxiety if you can possibly help it, especially with benzodiazepines. Tolerance and dependence tends to happen, not in a judgmental way, not in a drug addict way, but your body gets used to having these meds around. So if they're on for 2 weeks or longer, we really need to wean them off. You don't want to stop them abruptly, or we're going to have some serious, serious effects: nausea, vomiting, sweating, aching feelings, anxiety. And you want to use these benzodiazepines and other anxiety meds and sleep meds for specific reasons and behaviors, not just because the residents are bothering the staff. And if you think that doesn't happen any longer, you are wrong. I hear it happen all the time. I'm sitting there reviewing charts and it's, oh, you know, this person's annoying me, we need to get them on this medication. That's not what needs to be happening. And think, are there other specific reasons for anxiety that can be fixed? Maybe this person is worried about falling. That's a legitimate fear in an elderly person. And they're worried they might have to get up in the middle of the night to go to the bathroom. Get them a nightlight. That might help them. Get them a walker. That might help decrease the anxiety so that they have a pathway to go to the bathroom. Decrease their caffeine. People, as they age, metabolize caffeine differently. It sticks around a lot longer, those kind of things. And that can have that jittery anxiety effect on people. Decrease decongestant use is a really good idea. A decongestant like Mucinex D, things with the D in it, the Sudafed, pseudoephedrine, even the phenylephrine, that PE stuff, and the cold and cough remedies that you find over the counter. You want to decrease that use because that can make people feel jittery. Use it only if needed. Try to get people involved in calming activities, especially when they're getting to that sundowning time where people have sundowners. And make sure people are feeling relaxed. Again, with the insomnia and anxiety, decrease that caffeine intake, especially in the afternoon. Maybe they drank 6 cups of coffee when they were, you know, being CEO of a company. Maybe 3 is good enough now, and we stop at, 12 noon. Make sure that people are exercising regularly if they're able. That will help people sleep, and it helps decrease anxiety in most people. Decrease the daytime sleeping, encourage regular sleep hours. Now, if this is a person who stayed up all night in their daily life, that might be what they want to do in the nursing home, and that's okay. Make sure we're adequately treating pain. Pain can lead to anxiety, to insomnia, to depression. Pain is such an overwhelming thing for people, and some of these people have chronic, deep bone pain. It's something that needs to be addressed. Make sure that we're toilet training. Before they're going to bed, let's get you to the restroom. Make sure that we're not using diuretics close to sleep hours. Stop those diuretics at 2 p.m. or earlier if you can. Maintain a comfortable sleep environment for people. You want a low noise level. You want a temperature that's comfortable for the person, not for the staff. I'm often freezing or too hot in a nursing home, but it's not about me. It's about the resident. Maybe some dim lighting, few staff interruptions. I can't tell you how many times I've been in a nursing home late at night and staff are standing in the doorway of a resident's room, yelling gossip across the hall to someone else. That doesn't need to happen. And once I was in a facility, beautiful facility, it was probably 1 a.m., and they had some sort of glitch, which apparently happened fairly often, whereby the music that they played during the day, which was sort of just a fun, calming, classical repertoire of music, blasted. I mean, you had to cover your ears, it was so loud. About 1 o'clock in the morning every night, went on for an hour, and nobody could figure out how to shut it off. If that's happening in a facility you work in, you need to talk to the administrator and get that stopped. We alluded a little bit to the prescribing cascade. It's not as tranquil as it might sound. It's not a calming cascade of drugs. Basically, it's taking one drug and getting a side effect and taking another drug to fix that side effect, and then maybe taking another drug to fix the side effect from the first 2 drugs. It goes on and on and on. It's very common because the most common medical intervention we ask doctors to perform is to write a prescription. For example, there's a Medicaid database study that went on where Reglan, which you might be familiar with as metoclopramide, by the way, not the first line for GERD, it was being used for people to increase gastric motility or decrease acid reflux. And all of these people, compared to people who were not taking Reglan, were more likely to be on Sinemet, which is a Parkinson's disease. Now, Reglan, while it's for this nausea, vomiting, gut motility, molecularly is an antipsychotic, so it can cause those movement disorders. And you can see where we would go on and on with that. We've got Reglan, then we might give Sinemet. Well, what if somebody with the Sinemet then got a delusion? Well, then we might prescribe an antipsychotic. It can go on and on. As I mentioned, nurses really contribute to getting medications on the profile. So try not to be the start necessarily of a new psychotropic medication if you can possibly help it. Telephone orders for meds to control behavior should be limited as much as possible. Try to redirect if you can. Try to limit the duration and dose. Doctor, can we get a couple days of medication for this resident just so we can try it out, a low dose, something like that. Try not to lead someone to believe that we need to medicate this person forever with a psychotropic medication. And never, ever, ever medicate for staff convenience. When you get into this field where you're caring for people, it can be taxing, and sometimes you forget that you're here for them. But nurses and med aides and CNAs are really special people to dedicate themselves. You might be in a situation where you need to step yourself back before you just go to the phone and try to get a medication to sedate a resident, and that's okay. Just be really mindful that these people are delicate and they're in a fragile position, and these medications can have really detrimental effects. If you have any questions about this, please go ahead and contact us. It's a very broad topic, psychotropic medications, and we're happy to answer any questions you might have. Thank you.